I mean, it was great to be back in BTOG, I guess, is the first thing to say. And really in the first part of my talk, what I highlighted was the tremendous genomic advances that we've seen and experienced over the past 25 years. And so, I think it's important when we're stuck in the grind in the clinic and we don't necessarily see, it doesn't feel like genetic testing changes very fast. And so I thought it was relevant to remind people of the fact that in the year 2000, it took decades to sequence the first whole genome. It cost many millions of pounds. And of course now we can do it in the space of hours and it will cost less than £500. And so, the potential for health innovation and patient care moving on from that is fantastic. I think the problem we have now and what we need to manage is just all this data coming downstream, just finding the virtual space for all of that data, but ultimately just assimilating it all. What I said in the talk is that we really just have a list of parts, and we have over 20,000 genes in the genome. So how are we going to put the information all together for the benefit of patients? And that's a real challenge that we have probably for the duration of my career and all the trainees that are here as well. I focused in probably 3 or 4 examples of how we could absorb all of this data and use it for patients. In the middle of the talk, I described the smoking impact in the genome and different signatures that we can see in the genome that are related to smoking. And I guess the first thing to say is it's an incredible amount of mutations that smoking can produce. It will dominate the lung cancer genome in most cases that are related to smoking. And then we combined that sort of smoking imprint with clinical data sets. And I guess a key result was that we wanted to look at ex-smokers to see how long it took them to develop a smoking-related lung cancer, a cancer we could clearly see had a smoking imprint on their genome after they'd given up smoking. And the median amount of time was about 11 years in those cases, albeit there is a slight bias that it was a retrospective cohort. We had some cases of lung cancer that where patients had given up smoking very early in their life, sometimes in their 20s and 30s, and they were going on to develop smoking-related lung cancer 30 to 50 years later. Now that was a minority of patients, but I think the clear messaging from that is that patients and the public just should be trying to avoid smoking at all. There are potential clinical impacts of these smoking imprints if we over time think about incorporating them into the clinic. And for instance, we still see never smoking patients that don't have a clear driver gene. We don't know if they might have been subjected to passive smoking, and following on from that, it's really the smoking-related lung cancers that ultimately benefit from immunotherapy. So being able to know if it's a smoking-related lung cancer would be a useful addition to our genetic information. Also, it might have an impact on screening programs as well and age range eligibilities if we know that you give up smoking and can still develop a smoking-related lung cancer very late in your life. The last part of the talk was really describing co-mutations that are closer to what we want to absorb into the clinic very soon. And there are probably 3 main ones we discussed: SDK11 co-mutation, RB1 co-mutation, and P53 co-mutation. And in different ways, they all have a negative impact on immunotherapy or small molecule treatment in different settings, both the smoking-related and never smoking-related lung cancer setting. And so that's information that I think will increasingly steer our treatment options and our discussions with patients. And I think the clear message from the session was that most oncologists are very enthusiastic about the prospect of having that information from the next generation sequencing reports.